Thanks, everyone. Now we will be moving to our case number 4. I will request Professor Dr. Akif to please stay on the stage and have a seat for the next discussion. Now, for our next discussion, the case number 4, I will request our worthy professor, Professor Syed Asghar Naqi Saab, to please come on the stage and have a seat, please. Professor Asghar Naqi is currently working as a principal Allama Iqbal Medical College, Lahore. His continued medical, educational, it includes his participation in seminars, symposium, workshops, and congresses at national and international level. Professor Syed Asghar Naqi Saab, we welcome you, sir. Thanks for your presence, sir. Now I request Dr. Anisur Rahman Saab. He is the senior consultant radiologist, clinical lead for PET CT and body images, and working in Shaukat Khanum Cancer Hospital, to please come on the stage and have a seat, please. For my other panelist, I will request Professor Mughis Athar Saab. He is a professor of gastroenterology and dean of gastro division in Faisalabad Medical University. I will request Professor Asif Gul Saab to please come on the stage. He is a professor of gastroenterology in Services Institute of Medical Sciences. In our further expert panelists, I will request Dr. Najmu Sahar to please come on the stage. She is the assistant professor of gastroenterology and HOD of Medical Unit 2, Gujranwala Medical College. Now I request Dr. Fariha Sheikh. She is the assistant professor of oncology in Jinnah Hospital, Lahore. Madam, can you come on the stage, please? Now, for this discussion, I will request Dr. Muhammad Ali Saber. He is the clinical fellow and senior registrar in gastroenterology department, Jinnah Hospital, Lahore. I will also request Dr. Tariq Baloch. He is the senior registrar gastroenterology in Sheikh Zayed Hospital, Lahore. So Dr. Muhammad Ali, kindly come on the stage, please.
Thank you, Dr. Wes. Good noon, everyone. And with this, we'll be moving towards the 4th case of our day, that is CA head of pancreas. And to the audience, I know by this time of the day, the academic sessions mostly turn into a snooze fest, but stay hooked. This will be a really engaging session for sure, inshallah. So with this, I'll hand over the mic to my presenter.
Without further delay, I'm Dr. Tariq Ahmed. Thank you, Dr. Wes. This case is basically carcinoma pancreas, in fact, carcinoma head of pancreas. It is a 65-year-old gentleman who presents with progressive jaundice and associated pruritus, having these complaints for the last 12 to 15 months. And there is denial of weight loss, 20 pack years of cigarettes smoking, no known comorbid conditions. Keeping clinical history and clinical evaluation, ultrasound was advised, which shows a distended gallbladder and minimally dilated CBD with intrahepatic biliary channels dilatation, and prostate is enlarged. Bloods were asked for HB platelet and WBC count were within normal limit. The abnormality was found in bilirubin, which is raised 4.8, and raised alkaline phosphatase and ALT levels. So
now that, please play the images of MRCP. So now that we have the images of MRCP with us, I would like to request our esteemed radiologist, Dr. Anisur Rahman, to please go through them and enhance our knowledge, please, sir. Over to you, sir.
Okay, the MRCP images are showing significant intra and extrahepatic dilatation of biliary ducts. And we can see there is an abrupt cutoff at the ampullary end of the CBD without any meniscus sign, but there are some changes of mild irregularity over there. Fortunately, the pancreatic duct was not significantly distended. There is a small incidental cystic area seen in the region of, I think, left kidney. And nothing else is significant within the given images. Gallbladder is distended, containing dense debris, and so what we are expecting is an obstructing lesion at the ampullary end of the CBD. The next investigation should be the ERCP.
So MRCP findings, distal CBD stricture with retroculate dilatation of intra and extrahepatic biliary channels and a distended gallbladder.
So here, now that we have a clinical history, MRCP findings, I would like to move towards our esteemed Professor Dr. Akif Dilshad. Sir, if you were the attending in this case, how would you be liking to proceed?
We see the available information that patient's got a history of jaundice and he's got risk factor in the form of smoking, and in the history that he's not diabetic, blood sugar random was more than 200, so probably he was given some fluids and he's borderline diabetic as well if it's not diabetic. And then we have got an MRCP which is showing dilated extrahepatic biliary tree and possible stricture down the line. So we don't have a firm diagnosis in terms of etiology. So I think if the CBD is dilated and the possible pathology is down in the ampullary or head of pancreas area, the investigation of choice or go-to investigation should be the CT abdomen before jumping on to any intervention. And the recommendation and guideline says that CT abdomen with contrast, maybe thorax, abdomen and pelvis to get the whole picture before. He's got bilirubin of 4, and if he's got head of pancreas, he may be going straight to the surgery rather than ERCP with the bilirubin of 4. So I will go for CT abdomen with contrast first.
So we jump to the MRCP without CT scan?
Yes.
Yes,
There's no CT.
There was no CT scan, or we don't have in the record.
No, sir, we did not have CT scan by now. We did MRCP.
So that's
Yeah.
amazing.
Actually, that's a very valid.
So generally, if for the interest of audience and for the beginners, that if you have got distal obstruction, you must go with the CT first. And for proximal obstruction, CT plus the MRI to get the extent. If you are planning a procedure, you need to know the roadmap, whether the right or left duct is involved, or both of them are involved, or extent of the obstruction. In that case, in proximal, after the CT, you have to get the MRCP. And if you are to go with the MRCP, then at least it should be MRI, dynamic MRI with MRCP rather than just MRCP.
Sir, can I add here, as a patient is in denial of weight loss and alkaline phosphatase ranges less than 500, and to pick intraductal stones or sludge, the sensitivity of ultrasound is very low. So isn't it better that we should, instead of thinking so high of malignancy, we should have proceeded with initial investigations that are advised?
You don't have a stone in the CBD, and in the absence of stone and surgery, any structure in the biliary tree is a suspicion for malignancy. There's a strong suspicion, unless you have got a history of surgery where maybe post-cholecystectomy stricture you may consider, or if there is a stone, you may consider that the inflammatory stricture may be there. But in the absence of stone, in the absence of surgery, any stricture in the biliary tree, high suspicion of malignancy, rather than going ignoring it and thinking that it could be benign.
I think we must not forget that there's a case of 65-year-old male smoker who has progressive painless jaundice. So the differential of malignancy will come a bit higher up.
And you have got a dilated gallbladder as well.
Yes. The
So if
cruises
there is stone disease, usually the gallbladder is sclerosed and it will not distend. With that much distended gallbladder, that also raises the suspicion of a possible malignant etiology rather than stone disease.
So again, adding up to the Dr. Saher and Dr. Akif Dilshad, that considering age and risk factors, along with you didn't emphasis on the finding of ultrasound, that patient has a distal CBD stricture on the ultrasound. For structural abnormality of the ducts, we may proceed with the MRCP. Otherwise, we'll have good to have MRI dynamic with MRCP.
So you need to understand the overall picture, the overall presentation. The multiple factors come into play, like what is the age of the patient, whether this is a painless jaundice or painful jaundice, and if on initial ultrasound there are stones in the gallbladder, patient is relatively young, so we may be dealing with a case of choledocholitis. In such cases, you may go with MRCP, but considering his age, patient is having painless jaundice, gallbladder distended. In such scenario, the first investigation after ultrasound should be CT scan rather than MRCP.
20 pack diabetic we have.
20
So-
pack years of cigarettes as well. So another predisposing factor.
We proceeded with the bloods on 8th August 2023. Bilirubin jumped to 13.8 and the friction is a direct bilirubinemia and raised alkaline phosphatase and mild transaminitis is there. So, plan was to proceed with the ERCP. It was a difficult cannulation for which double duct technique was adopted. Pancreatic stent was placed, followed by biliary stenting. So these 10 into 10 centimeter plastic stent, CVD, and 5 into 5 PD stenting was done after obtaining the cholangiogram and outlining the stricture in distal CVD with retrograde dilatation.
My question from Professor Asghar Naqvi would be, in this case, if the tumor markers may be raised in benign obstructions too, but at this age, if the CT shows a characteristic enhancement pattern and the tumor is clearly resectable with a bilirubin of 13, would you straightway go for surgery or involve gastroenterologists and do an ERCP?
I would like to go for surgery. But in this case, if ERCP was done, did you take any brushings or was there any biopsy of this
No, sir.
patient
no
done at the same time?
No brushings were taken so
No
far.
brushings,
No,
no
sir.
biopsy.
No, so far.
So, sir, what is
So I
your
think-
threshold
so
for?
I think we need to put it straight that this is not the ideal scenario, and patient should have undergone a CT, tumor markers, and then surgical consult with reference to if surgeon can wants to go with the surgery. Usually in the range of 12 to 13 surgeons are comfortable and proceed direct to the surgery if it is malignant disease on CT. So course corrections for those who are listening, that the message is loud and clear that we need to do CT for every distal obstruction and involve the surgeon if the bilirubin is in the lower range, 10, 11, 12. So surgeon may proceed directly to the surgery rather than doing any ERCP.
Yes.
And let me also tell you the reason surgeons would like to go in first is once you've done an ERCP, and we've recently done a case where 2 ERCPs were done, and there was too much duodenitis and post ERCP pancreatitis, so the dissection planes were all involved, so it was difficult to dissect in that area. So I would like to go in an area which has not been invaded first, easier dissection planes, provided that CT told me that it was a plainly resectable tumor.
What's your
At what bilirubin level you would say that I need a drainage procedure first? For the interest.
You see, the ALP is still not raised much. Is
Not
it still
for this patient, for general
Okay.
cutoff. Any cutoff, do you think that beyond that you need a drainage? Yeah, your anesthetist need a drainage.
I think 15 would be a cutoff for me.
250 micromoles or 13, 14 milligrams of bilirubin is the cutoff for according to the guidelines.
So-
But let's not forget that it is an ideal scenario that you 65 years of age of patient and diabetes and comorbids and gets a WIP. You were talking about a Whipple procedure. So patient's wishes, family decision, everything else also comes into play. Also, the surgeon, obviously Naqvi Saab would do straight away the surgery, but we are not that fortunate to have surgeons so
Anesthetist.
eager to do.
There is an anesthetist between surgeon and physician as well. So you need to see him as well. He maybe wanted to do it, and the anesthetist may say that I need a lower bilirubin. So I agree, 10, 12, surgeon's preference is to go without draining, and that is very logical. But if it is more than 14.5, 15, then probably anesthetist will not prefer to operate.
Sir,
And
here I want to
another
ask.
thing which Dr. Najam has said actually is, what is the purpose or benefit of doing a Whipple in a 65-year-old person? And some people are of the opinion that Whipples basically are a palliative procedure, which I would say is, as a surgeon, I would say it is not. Especially if the tumor is resectable. And अब चूंकि मैंने इसकी histopath भी देखी हुई है, then in all cases I would still like to resect where possible because it has been proven. And because it's at the lower end of CPT, it's most likely a cholangiocarcinoma, and cholangiocarcinomas, they behave much more better than the pancreatic ductal adenocarcinoma. So in this case, I think still, and age is just a number if the patient is fit.
Sir,
I will
even
endorse, sir,
even
because
it's
as an
Do not forget
as an
that the
oncologist,
peak
we
age
also
for
go-
this carcinoma is 65 to 69 in males and 75 to 18 females. So present in this age, if the functional status is good, age is not the bar.
Definitely, if functional status is good, then we have to go for the definitive treatment.
So the long-awaited CT is in, sir, you want to say anything, please?
Other than the bilirubin level, cholangitis or infection might delay the surgery or not. So we should consider cholangitis or history of fever in such cases along with the raised TLC and CRP levels.
I do agree with Professor Asghar Naqvi. Treatment of choice is surgical resection along with adjuvant chemotherapy for next 6 months. I think so. This is the standard procedure for such tumor.
sir,
As far as I remember, when I started my house job, Professor T.A. Shah was doing routinely Whipple procedure, 1 to 2 Whipple procedure on each list. And he's the, I think so, father of Whipple procedure in Punjab.
So the long-awaited CT is in front of us. I would like Dr. Anis to please go through it and maximize our knowledge, please.
So, how many days or weeks after the MRCP, the CT
So
was done?
27th July was the timing of MRCP, and it's 30th of October of the same year that is the time of the CT.
So, any clue why there is that much big gap?
So that was at the discretion of the attendings.
Sorry?
That was to the discretion of the people who were attending the patient.
Okay. So, after quite suspicious findings on MRCP, there is almost 4 months gap for the next investigation.
So the patient presented after 15 months of jaundice. You can well imagine the
No, I mean-
compliance of the family.
The first,
No,
I
sir,
mean-
that is a multi-centered patient. He was moving around a lot of hospitals, one thing from one side and one from the other. And he actually presented after worsening of his symptoms that started about 15 months back from the presentation.
but still, if in one special investigation there were quite alarming findings and red alert to raise the alarm for like malignancy, then 4 months are too much. Anyway, over here we can still see there are dilated intra and extrahepatic biliary ducts with stent in place. And we can see there is some ill-defined nodularity medial to the stent margins extending to the ampulla. Other than that, no significant disfigurement of the pancreatic head can be seen, slightly prominent pancreatic duct noted. And now if we can look at the vessels, the portal vein is intact. There is slight soft tissue haziness adjacent to the posterior margins without any invasion. And then the celiac axis, common hepatic artery, they are essentially preserved. Still, we will consider it like if we can measure these changes, maybe a T1 lesion hardly at this level.
Is there a 3D reconstruction available of the CT?
No, sir,
Can we
this
have
is,
a look at the vascular, is there any aberrant? Because I don't think there's any aberrant right hepatic in this patient.
So this was all we could collect for this patient.
I think.
All right. So if a surgeon would like to see this, would be
Yes, sir.
1, the superior mesenteric artery and its relationship. 2, as Anisa Wester told us about the superior mesenteric vein and its relationship with the tumor.
Yeah.
And then any aberrant or anomalous vessels here, especially because of the right hepatic artery may sometimes take off from the superior mesenteric artery, and then the inferior pancreatic or duodenal sometime also. So that is something which the surgeon would like to know beforehand, if possible.
Can we move to the report of CT, please, sir?
So CT scan report conclusion CBD stent in situ, bilobar moderate to marked intrahepatic biliary dilatation, suspicion of mild soft tissue thickening in distal CBD could be due to mass or stricture.
I would like to stop here and ask Professor Dr. Asif Gul, sir, with this CT findings, this MRCP and the ERCP, how would you like to take this case further up if you were the person attending it, please?
As already Professor Asakani comment that we have, you can say, more CT images, and then develop and look again and how sinister looking lesion this is, number one. And if still CT, and again I will go back to Dr. Faria, we should involve the radiologist here, develop a multidisciplinary approach. And if all the team will decide that this is CBD stricture, then definitely again going back to ERCP, and with the availability of the spyglass and taking the biopsy specifically of the stricture site would lead to any diagnostic, final diagnosis.
So here I would like to put a question to Professor Naki. Sir, as the available data is, there is no tissue diagnosis, there is no confirmation on radiological findings. In elderly patient whom we are thinking of that this patient is having a malignant lesion, even then would you like to proceed with surgery?
If available, I would like to have an EUS and EUS guided biopsy of the mass which appeared on the CT, if possible, if we have that. Otherwise, we need to discuss it with the patient, that what are we thinking and what are the other options. And then I would have to perhaps do a diagnostic laparoscopy first and then decide about operability or otherwise.
What were the tumor
Tariq,
markers?
we don't have tumor markers
what were the
at
tumor
this point
markers?
as well. So we need to do, we need to check the tumor markers as well. And at least 1 to 2 attempts should be made to get a tissue out of it. You may not be able to get it. It's a small area. If the duct is thickened down there, EUS guided biopsy can be attempted, and you may get a tissue diagnosis out
Sir,
of it.
if
And tumor markers must be done at this stage.
Isolated, talking about tumor markers, isolated tumor markers, how much you will rely on?
Isolated तो नहीं है, mass तो नजर आ रहा है आपको. Isolated होता है वो जब mass ना हो. So there is a mass. So you put.
Up till now, stricture is there, and
There is thickening. Sir. हाँ, CT पे इतना ही नजर आएगा thickening. Even if you see it on US, there will be thickening of the wall, and you will be able to target it with the needle. And you need to see the tumor markers as well. In the absence of stone, in the absence of surgery, any thickening, a good segment of cholangiocarcinomas present with sclerotic thickening only and not the mass. So you need to see whether this is a sclerotic type of stricture or a mass forming cholangio. And if possible, an EUS should be targeted for biopsy, and tumor markers will give you a support even if EUS is not available and surgeon is planning for a surgery. A high CA19-9 will definitely help.
If a significant rise in tumor
Dr.
marker
Faria,
is
you were
there,
asking.
then, yes, if there is a significant rise in tumor marker, then that is highly suggestive in the context of all the previous
Dr.
scenarios.
Faria, at this point
I understand your concern that CA19-9 could be falsely elevated on obstructed biliary tree. That is
at this
that is
point
true.
of time, it was borderline raised. It was inconclusive. Ma'am, the CA19-9 at this point of time with this soft tissue swelling. Can we move forward, please?
so patient lost to follow presented exactly after 6 months with the features of cholangitis, and there was an urgent call for ERCP previously and that was planned, and previously placed stent was removed, a self-expandable metal stent was placed, and good flow established and pus seen coming out of the ampulla after stent placement.
तारिक, ये पेशेंट ने कहा मैंने सर्जरी नहीं करवानी है, हमने सोचा कि हमने नहीं करनी है.
Sir, ये बता सकते.
Sir, here that question
I
is
will divert
answered
it
that he
towards-
was again lost to follow up for 6 months until
पेशेंट का जो behavior है वो भी है कि 6 माह बाद ये CT के 6 माह बाद ये procedure हुआ है.
Actually, the
months
problem
Probably we
is,
give the benefit of doubt to the whosoever done the procedure.
Actually-
that this patient is not
Yes, sir.
that sort of patient who follows the advice, and he may be reluctant for the surgery. That is why probably a stent was placed again.
A lot of problem actually comes from कि initial ERCP हो गई, jaundice relieve हो गया,
Yes, ma'am.
better हो गया, patient के symptoms improve हो गए, so they think that it's done. So even if we are not pushing, they will not go further.
उन्होंने कहा डॉक्टर ऐसे ही कहे जा रहा है, साल तो हो
हाँ
गया
जी,
है
पहले ही
और
जिंदा है
ठीक-ठाक
तो
चल
जिंदा
रहे हैं,
रहेंगे
कुछ नहीं हुआ फर्दर.
Coming back to Dr. Anis, sir, this was the second CT scan done on 25th of May next year. Can you please go through the findings and guide us?
Now, after all the efforts of the patient, and I don't know who is involving in this whole scenario, there is a T4 malignancy over there, and stent is placed still, but there is a sizable mass in the pancreatic head now.
किस साइज का स्टैंड डाला है, मेटालिक स्टैंड, लेंथ?
10 mm का होगा.
By 10.
It is important that even if you have to place a stent, metallic stent for drainage, for distal strictures, do not use longer sizes of the stent, that it may hamper on further surgical interventions.
So over here we can see now this is the pancreatic head lesion, and the incinate process is blurred. There is dilatation of the pancreatic duct, and if we can go back on the arterial face, we can see that the vessels are also involved.
सर ये पहले क्यों डिस्टल सीबीडी में नजर आ रहा था?
No, actually the thing is it was a periampullary lesion, I think. It was small size. Even after 6 months CT scan, it was still T1 at that level, less than 2 centimeter. So it extends from the periampullary towards the pancreatic side, and now this is quite sizable over here. We can see the SMA is involved. It is abutting the portal vein as well, and if we can see this one, the common hepatic artery is also abutted with this, making it a T4 lesion. Still, fortunately, no hepatic metastasis seen, which can be done in next stage.
सर एक मासूमाना सवाल आपसे प्रोफेसर अनीस साहब, कैन वी डिफरेंशिएट इन benign and malignant strictures on the basis of MRCP, any specific findings, and CT scan?
Yeah, there are certain findings which can raise the possibility of malignant or benign narrowing of the CBD. One is location, the other thing is the morphology, the margins. If we can see a meniscus sign, we can, for sure, we can say that this is a stone obstructing the CBD. If the structure is smooth and short in the region of periampulla with history of previous pancreatitis, then we can think maybe a sequel of previous pancreatitis. But if the margins are irregular, as we can see in this case, the mucosal margins were irregular at the interstitial and transition site. And we were very much sure at that time that it's a malignant stricture.
Sure.
To the slides, please.
CT has been discussed. Now a metallic stent is there, and there is a heterogeneous mass seen involving head and uncinate process of pancreas, which shows internal hypodense areas and subtle arterial enhancement. This mass extends up to aorta posteriorly. It is abutting the superior mesenteric vein posteriorly with less than 180 degrees of its circumference. The mass is encasing SMA. This mass is seeing abutting duodenum as well, suspicious for advanced pancreatic malignancy. So here comes the CA19-9, there ayat durust, more than 12,000.
I would like to move towards Dr. Najmus Seher. Please, ma'am, what's your opinion in the given clinical context about the EUS, endoscopic ultrasound and biopsy, please?
बेटा उसका भी टाइम गुजर गया. Actually, now it is actually ball in Dr. Faria's court. So next thing would be a chemotherapy, or maybe surgeon, if they are too aggressive, they can do a surgery instead. But as far as US is concerned, that was the thing use. मतलब जो आप पूछ रहे थे ना कि स्ट्रक्चर के लिए MCT और MRCP पे वो कभी भी फाइनल नहीं होता, जब यूएस पे हो सकता है. ठीक है, तो यूएस पे बायोप्सी लेके टारगेटेड लीजन की अगर, तो दैट मे बी द थिंग मेक आवर लाइफ इजियर.
So Dr. Faria, since ma'am has thrown
आपने भेजना तो उन्होंने वापस भेजना है कि get the tissue diagnosis before chemotherapy.
Yeah,
so
so
you,
that
you
was
have
my
to get
question.
the biopsy. That is
Yeah.
one indication for locally advanced tumor. That if we are considering for chemotherapy, generally oncologist needs a biopsy.
अब तो चाहिए ही चाहिए.
So get a biopsy done and then send.
So that was the question, Dr. Faria, that
Because
would you
prior to proceeding surgery, because आप in that context अगर benign lesion भी है, patient को bother कर रही है, high risk disease है, it's clearly resectable, तो you can proceed for surgery directly. But for chemotherapy, we really need कि हमारे पास tissue diagnosis हो, because sometimes we get a very rare diagnosis, just like the previous one, उसमें pancreatic TB निकल आई, sometimes lymphoma निकल आया, carcinoid निकल आया, there are atypical histologies. So in that case we have to decide the chemotherapeutic agent, और surgery वाकई चाहिए भी थी या it's lymphoma, तो patient doesn't require surgery at all. So in the, for giving a systemic therapy, we need to have a tissue diagnosis. At least 2-3 जो guidelines recommend करती हैं कि at least you have 2 or 3 attempts. अगर वो नहीं हो पा रही, in that case, अगर considering this much high level of CA19-9 and scenario, then we can proceed for.
बट अब जो जिस तरह आप मैथ्स है, आप तो यानी चांसेस हैं कि यू विल गेट टिश्यू, जो पिछला था छोटा, उसमें था कि मे बी एक करें 2 करें ना आए. अब ये तो सिग्निफिकेंट मैथ्स एंड दैट कैन बी टारगेटेड इजीली.
विद एवरी पासिंग डे जितनी एडवांसमेंट्स हैं इन ऑन्कोलॉजिकल ट्रीटमेंट्स, every pancreatic mass needs to have a genetic analysis before proceeding for systemic therapy. तो उसमें अगर हमारे पास tissue diagnosis होता है तो it's easier कि आप उसकी mutational analysis करा लें, because otherwise we proceed blindly कि अच्छा ये therapy ये दे सकते हैं. लेकिन अगर tissue diagnosis हो and we go for a targeted testing, तो उसमें we are able to give targeted therapies as well.
Sure.
Sir Akif, without deciding final fate of the patient, first stent was removed and second stent was a self-expandable metal stent, and still we were unclear about the things. What could have been the reason putting a metal stent in a case? Still we are thinking.
One reason could be that I noted, I've seen the report in the presentation, and it states that pus was seen coming out of it. So probably the previous plastic stent may not be draining well, and the patient may have presented with cholangitis, and the operator thought that instead of placing a plastic stent which may not drain well, he thought of draining it well, considering that patient is not for surgery or doesn't want to go for surgery, so at least his drainage should be adequate. That could be the thought process, that in cases of cholangitis you tend to place either multiple plastic stents, which may be difficult in this tight stricture, so it is easy to place a metallic stent to get a good drainage. Even if you have to place that metallic stent in cases of cholangitis, the preference is to place the smaller stent, so that it generates less fibrosis and less difficulty for the surgeon.
towards the slide, please.
So US was planned and US guided biopsy and histopathology result was well differentiated adenocarcinoma.
So here now that finally we have tissue diagnosis, we have imaging findings that we were looking for. So I would like to involve our worthy surgeon professor, Dr. Aswar Naqi and Dr. Fariha, both of them, that what do they both think should be the course of action, a neoadjuvant or direct surgery, a small MDM, we can consider it, please.
Yeah, now at this point of time, after the second CT and that, we have seen that the size has increased quite a bit, and we now have a tissue diagnosis. Now the role of neoadjuvant chemotherapy in pancreatic cancer is a very controversial subject actually, and most of the people are not in favor of it, especially with the older generation when they used capecitabine. Now with FOLFOX they have reported better results, and so I would go for somebody who knows this subject better than me, I'll ask Dr. Fariha what does she think about it.
Yes, ma'am, please.
There are two things. एक तो है कि the tumor is clearly resectable. In that case, जो role of neoadjuvant is controversial. But in this particular case, when the tumor is unresectable or borderline resectable, now there is a role of neoadjuvant therapy. So previously, as sir mentioned, कि वो single agent gemcitabine या gem based therapies थी, तो they were not that effective. But currently, extrapolating the data from metastatic setting, जो 5FU based regimens, they are more effective. And recently there was a meta-analysis of 16 retrospective studies which mentioned that almost one-third of the patients who were given chemotherapy in neoadjuvant setting for borderline resectable patients, they were rendered resectable. So this is a quite big number कि अगर हम neoadjuvant देते हैं तो चलें अगर patient resectable हो जाता है, that is very good. Otherwise, a control of disease can be achieved with chemotherapy. And the guideline recommends that if the patient has becomes resectable, then you go for resection. Otherwise, complete chemotherapy as per the response of the patient.
Thank you, ma'am. Towards next slide, please.
So MDM neoadjuvant chemotherapy was decided. 7 sessions of chemotherapy were done on alternative weeks, and the formula, there is a capecitabine, 500 milligram, 3 plus 0 plus 2, 7 days, then alternative week. So CT scan was repeated, metal stent seen. There is impression of internal and enhancing soft tissue within the stent. There is increase in intrahepatic dilatation, CVD measures 11 mm in mixed diameter on coronal image, suspicion for growth of a tumor within the stent. Small hyperdense calcific foci is seen within the gallbladder. There is interval reduction in previously noted heterogeneous mass involving head and uncinate process as decreased in size. However, there is still ill-defined thickening seen head and uncinate process. Patient was referred for surgical intervention. Bloods were ordered. Bilirubin has settled HB12 platelet PTINR within normal limit. Good liver function test, albumin is 4.5. Echo normal, cardiac fitness, anesthesia fitnesses were done. So surgery was planned. Patient was put on list for pilus preserving pancreatoduodenectomy. Intraoperating finding were mass at head of pancreas. Post-op management, patient was monitored in ICU.
No, sir, that's a picture, not a video. No, sir, that's not a video. That's a
patient was mobilized, uneventful recovery continues, and patient sent home. So post-op investigations, first post-op day, HB 11.5, TLC slightly higher side, platelet, and for right side drain 70 ml and left 100 ml, output 2300 and CVP was 7. On day 2nd, patient mobilized, chest care was given. On day 3rd, drain output on right side 100 ml and on left side it was 280. Sufficient urine output and CVP was 6 centimeter. And 3rd post-op day NG was removed, oral sips allowed, and labs were repeated and were satisfactory. So histopathology report, moderately differentiated adenocarcinoma, all resection margins are free of tumor.
So this is the tissue diagnosis, the specimen diagnosis. Towards the end of the discussion, I would like to move towards Professor Asghar Naqi. Had he been doing this surgery and this patient actually decides to follow up for the first time, sir, so what would you be suggesting, that what would be your follow-up plan for this patient? Would you be liking an oncologist input in that, or what?
I would like to have, because he's received the neoadjuvant chemotherapy,
Yes.
and though the all resection margins are clear, and the tumor size is also reduced. The lymph node yield was, there were 18 nodes and only one of them was positive, but still one was positive. So there is still a chance this patient would require adjuvant chemotherapy.
So, Dr. Fariha, what would be your input here, please?
Normally we give 6 to 8 months of chemotherapy, so we will complete, if he hasn't received the full chemotherapy prior to surgery, then we will complete the remaining part of the chemotherapy after that.
On behalf of the gastroenterologist, Professor Akif Dilshad, I would like you to comment that what would be your perspective regarding all of this?
Patient should be followed up. I think again, those who have got raised CA19-9 should be followed up. One thing with the CA19-9 that in those patients, it has got prognostic value, and if there's recurrence, it will rise again. And maybe every 3 months, and CT is recommended between 3 to 6 months in different societies. European says every 3 months, and then other societies say 6 months. So CT 6 monthly for first 2 years, and then maybe yearly. Although a meta-analysis mentioned that the overall survival was not different in those who were followed and those who were not followed.
So the most important learning point from this case is, in such cases, early MDT is the most important thing to do to avoid such gaps in the management, to avoid the undue delay in the surgery that happened in this case.
And this patient was lucky in the sense that his tumor was somehow slow growing.
And I have a question from Professor Askarnaki. In cases where on initial imaging the tumor is clearly resectable in cases of head of pancreas, do you suggest to do EUS guided FNB to establish tissue diagnosis? Because there's some data of the surgical specimen, like in 10 to 15% of the cases, you may find benign causes.
There are benign indications of doing a Whipple. So you do a resection, and if the resection is possible, there are other indications besides malignancy of.
So there may be, patient may be having autoimmune pancreatitis, and that may be responsive to the drug therapy and undue surgery in that case.
And I agree with that, but I would not like always to have a biopsy first. Riyaz sahab se bhi pooch lete.
Before we ask Vyasa, can I ask a question? Has the staging CT been done in this patient before deciding whether the tumor is resectable, we are going for surgery or not? Has the staging CT been done?
After neoadjuvant chemotherapy, there was interval reduction in the size of a tumor.
No. Staging CT means chest, abdomen, pelvis.
That staging CT, that was...
No chest CT?
Chest CT.
There was no chest CT available.
All right, so...
No,
I think, we should follow the guidelines to stage the tumor first before deciding whether the tumor is resectable or not. Secondly, what about the vascular involvement in the CT? And did we confirm that on EUS?
No, ma'am, there was no comment about that on EUS, but that was just
and on
CT.
CT?
Yeah, that was on CT. CT, that was showing, ma'am, the involvement of the vessel abutting 180 degrees, less than 180
less
degrees.
Less than 180, okay.
Dr. Priya,
a question...
The vascular abutment was before the neoadjuvant chemotherapy. After the neoadjuvant, they said the size has decreased, and the CT that they showed did not have that.
Question for Professor Naki. Sir, manipulation of CBD with stent make the surgery a bit difficult. So is it for metal stents or for plastic stents, or is it for any specific time or?
अच्छा आप पूछ रहे हैं मैं ढूंढ रहा हूँ सवाल कौन पूछ
Yes, sir, इधर से question is
I'm sorry
Sir, manipulation of CBD with stenting makes the surgery difficult. Is it for metal stents or for both plastic stents, or it is duration dependent?
I think it depends upon the times of ERCP that has been done. Most of the cases that I have operated had plastic stents in them, so I do not have a personal experience of metallic stents in place. But yes, plastic stents do cause a lot of reaction, and there is fibrosis, and the dissection planes are altered.
Sure. Thank you.
जो मेरे ख्याल में जो सबसे मेन इसकी जो लर्निंग जो पॉइंट था, वो एक तो ये था कि बंदे को अपनी तरतीब ठीक रखनी चाहिए. मतलब इसका सब कुछ ही उलट पुलट हुआ है. सबसे पहले इसका MRCP हो गया, अल्ट्रासाउंड का दूर तक नामो निशान नहीं है. उसके बाद साल के बाद वो फिर आया, फिर उसका जनाब वो एक CT हो गया, फिर वो गायब हो गया. मतलब जो एक तो तरतीब ठीक रखनी चाहिए, दूसरा ये कि हमें स्ट्रेस करना चाहिए कि पेशेंट एजुकेशन जो है ना वो बहुत इंपॉर्टेंट है।
Yes, sir.
अगर उस पेशेंट को प्रॉपर उसको बताया नहीं जाएगा कि इसके क्या कॉन्सिक्वेंसेस हो सकते हैं या क्या मसला होगा, तो मेरा ख्याल में दिस इज़ अ लर्निंग पॉइंट फ्रॉम माय साइड।
Thank you very much, Dr. Anis. There are so many learning points from this discussion. I will request Dr. Gyas to please comment, to give his
मैं
comments,
दो
please.
चीज़ों में कमेंट करूँगा। एक तो हिस्टोपैथोलॉजी और टिश्यू टाइपिंग बिफोर गोइंग एट फॉर सर्जरी, आई थिंक दैट्स वेरी वेरी इंपॉर्टेंट. In these days, taking a biopsy, image-guided biopsy, may it be CT-guided or may it be endoscopic ultrasound-guided biopsy, that's very important. Endoscopic ultrasound-guided biopsy is very precise, very good, very convenient for the patient with minimal mobility and absolutely no mortality. It gives you the result on site. It is a core biopsy. It's not aspiration cytology alone. And I've seen number of cases where based on imaging, the diagnosis was the patient suffering from advanced acute malignancy. But then on histopathology, we came to know that it's a chronic inflammatory, most likely IG4-related disease. We gave corticosteroids and the patient recovered within 7 to 10 days. There was absolutely no mass. Number two, at times people are suffering from neuroendocrine tumors, and then people can have aggressive tumors, people can have relatively tumors with less proliferative activity. So there are lots of things which need to know, which we can learn by taking the biopsy before proceeding for the surgery. And secondly, coming down to the reactions of the plastic stents. Well, plastic stents are by and large benign. They are inert material. They don't lead to any tissue reaction. The tissue reaction comes from the metal stent. Now there are pros and cons. With plastic stents, we can have a narrow diameter, but they are inert. If the drainage is not proper, if they're left for too long, definitely there's going to be reaction for infection. With the metal stents, they're wide diameters, the drainage is very good, bilirubin comes down very quickly, but they lead to lots of tissue reaction. So coming down to Shasa's point, that he's seen plenty of reaction because of the plastic stent. Possibly that reaction was not because of the plastic stent, rather that reaction was because of the persistence of infection and inability to take care of the drainage in a proper fashion rather than the plastic stent per se itself. With the metal stents, yes, word over the consensus is that get the bilirubin down and operate as quickly as possible. Otherwise, once the drainage has been done, maybe fully covered metal stents, they lead to less tissue reaction, and fully covered metal stents are the way to go if the person has to go for neoadjuvant therapy and not the partially covered stents.
Thank you very much, Professor Gyas. So this brings the end of this discussion. Thank you, Dr. Tariq Baloch and Dr. Muhammad Ali Sabir, for elaborating this talk.